Welcome to another episode from the Veterinary Medicine Digest. Today we are diving into a human topic, but I hope you find it interesting. We are going to explore the profound clinical and pathological complexities of Behçet's disease, a multisystemic inflammatory disorder that serves as a cornerstone for our understanding of variable vessel vasculitis. This condition is unique in the realm of clinical immunology because it possesses the capacity to affect every size and type of blood vessel in the body, ranging from the delicate capillaries in the dermis to the large muscular arteries and the major venous structures like the vena cava. Historically, this condition has been referred to as the Silk Road disease because its distribution mirrors the ancient trading paths that once linked the Mediterranean basin to the empires of East Asia. The epidemiological data for this disease is quite remarkable, showing a stark concentration in regions like Turkey, where the prevalence can reach 421 cases per 100,000 adults, while dropping precipitously to less than 1 case per 100,000 in the United Kingdom. This striking geographic variation has long suggested that the pathogenesis of the disease is rooted in a specific and complex intersection of genetic susceptibility and environmental triggers. When we examined the genetic architecture of Behçet's disease, the most well-established marker is the human leukocyte antigen B51, which is present in approximately 60% of patients, particularly those in high-prevalence regions. However, modern genomic science has revealed that the genetic story is far more nuanced, as genome-wide association studies have identified other susceptibility genes, such as the endoplasmic reticulum aminopeptidase 1. Interestingly, there appears to be a significant epistatic interaction between human leukocyte antigen B51 and the endoplasmic reticulum aminopeptidase 1 gene, suggesting that the way the immune system processes and presents antigens is central to the development of the disease. The current scientific consensus is that in a genetically susceptible individual, an unknown environmental stimulus, perhaps a microbial exposure, triggers an exaggerated innate and adaptive immune response. This leads to a profound dysregulation of the pro-inflammatory cytokine cascade, characterized by elevated levels of tumor necrosis factor alpha, interleukin-1 beta, interleukin-6, and interleukin-17. The clinical presentation of Behçet's disease is famously heterogeneous, often requiring years of observation before a definitive diagnosis can be established. The hallmark of the condition, and almost always its first clinical manifestation, is recurrent oral aphthosis, which is observed in 97 to 100% of patients. These oral ulcers are typically painful and can manifest in 3 distinct forms: minor aphthe, major aphthe, and herpetiform ulcers. Minor aphthe are small, shallow lesions less than 10 mm in diameter that usually heal without scarring, whereas major aphthe are larger, deeper, and frequently result in significant tissue loss and scarring. These lesions can appear on the tongue, the buccal mucosa, the gums, or the soft palate, often making basic functions like eating and speaking extremely difficult for the patient. Closely following oral ulcers in diagnostic importance are genital ulcers, which occur in 60 to 90% of cases. These ulcers often involve the scrotum in males and the vulva or vagina in females, and unlike oral ulcers, they have a higher propensity for causing permanent scarring, which can serve as a vital clinical clue even years after an acute episode has resolved. The dermatological landscape of Behçet's disease is equally diverse, featuring a wide array of skin lesions that are central to the diagnosis. Patients frequently develop papulopustular or acneiform lesions, which can appear on the trunk, extremities, or face. A highly characteristic, though not always sensitive, diagnostic feature is the Pathology reaction. This phenomenon represents a state of altered tissue reactivity, where a minor trauma, such as a sterile needle prick, induces the formation of a papule or pustule within 24 to 48 hours. While the Pathology test is highly specific for Behçet's disease, its sensitivity varies significantly across the globe, being much higher in Mediterranean and East Asian populations compared to those in Northern Europe or the Americas. One of the most complex skin manifestations involves erythema nodosum-like lesions, which appear as tender, warm, erythematous nodules primarily on the lower legs. A detailed clinico-pathological study conducted at Saga University in Japan examined 26 patients to clarify the true nature of these lesions. Their research revealed that only 27% of the lesions were histologically indistinguishable from conventional erythema nodosum, which is characterized by septal paniculitis. The remaining 73% were histopathologically defined by the presence of true vasculitis, specifically venulitis or phlebitis. Interestingly, the researchers found that patients with the conventional septal paniculitis pattern tended to have a milder disease course. Conversely, the presence of severe vasculitis in these skin lesions, particularly phlebitis involving the muscular veins in the subcutaneous septa, was strongly associated with severe systemic disease and gastrointestinal involvement. We must now turn our attention to the more severe and potentially life-threatening aspects of the disease, specifically Neuro-Behçet Syndrome and major vascular involvement. Neurological disease affects approximately 5 to 10% of patients and can be broadly categorized into parenchymal and non-parenchymal involvement. Parenchymal disease accounts for the vast majority of cases and typically involves the brainstem, cerebellum or spinal cord, leading to subacute symptoms like cranial nerve palsy, cerebellar ataxia, and pyramidal signs. Histologically, these central nervous system lesions are characterized by a perivasculitis with a distinct venous predominance, often showing lymphocytic cuffing around the small veins. On magnetic resonance imaging, a characteristic finding in some patients is the Behcl sign, although diagnosis still relies heavily on clinical suspicion and cerebrospinal fluid analysis, which typically reveals a pleocytosis and elevated protein levels. Non-parenchymal disease often manifests as cerebral venous sinus thrombosis, which presents with signs of increased intracranial hypertension, such as severe headache and papilledema. Major vascular involvement is another defining feature of Behçet's disease, where the inflammatory process can lead to arterial aneurysms or venous thrombosis. Arterial lesions are less common but are a major cause of mortality, particularly when they involve the pulmonary arteries, leading to aneurysms that carry a high risk of rupture and massive hemoptysis. Venous disease is more frequent and typically manifests as deep vein thrombosis or superficial thrombophlebitis, where the thrombus is noted to be remarkably adherent to the vessel wall, thereby reducing the risk of embolism. The management of these vascular complications remains a point of clinical debate, specifically regarding the use of anticoagulation versus aggressive immunosuppression. Many experts now advocate for intense immunosuppressive therapy with agents like cyclophosphamide or tumor necrosis factor inhibitors to dampen the underlying vessel wall inflammation, which is the primary driver of the thrombotic events. The management of Behçet's disease requires a nuanced and organ-specific approach, often necessitating the collaboration of multiple specialists. For mucocutaneous disease, topical corticosteroids and colchicine are the standard first-line treatments. Colchicine is particularly effective because it inhibits neutrophil chemotaxis, thereby reducing the intensity of the acute inflammatory response. For patients whose symptoms are resistant to these conventional therapies, clinicians may turn to more potent immunosuppressive drugs such as azathioprine, mycophenolate mofetil, or cyclosporine. A fascinating case report from Timaru Hospital in New Zealand detailed the successful use of low-dose thalidomide in a 33-year-old woman whose disease was refractory to prednisone, dapsone, and colchicine. This patient suffered from severe oral and genital ulcers, as well as a coexisting condition called complex regional pain syndrome type 1, which caused debilitating pain in her left knee. Remarkably, after commencing low-dose thalidomide, her ulcers healed completely, and her chronic regional pain unexpectedly disappeared. This therapeutic effect is thought to be due to thalidomide's potent ability to block the production of tumor necrosis factor alpha in activated macrophages, highlighting the critical role this cytokine plays in both vasculitic inflammation and neuropathic pain. In recent years, the introduction of biological therapies has transformed the treatment landscape for Behçet's disease. These include tumor necrosis factor alpha inhibitors like infliximab and adalimumab, as well as inhibitors targeting interleukins like interleukin-1, interleukin-6, and the interleukin-12/23 pathway. For instance, a groundbreaking case study from Taiwan described a 43-year-old woman with the Behçet's disease and severe persistent allergic asthma, who was treated with subcutaneous omalizumab, an anti-immunoglobulin E monoclonal antibody. While the treatment was intended for her asthma, it resulted in a significant and unexpected improvement in her recurrent aphthous lesions, with laboratory analysis showing a notable decrease in her levels of interleukin-6, interleukin-33, and interleukin-25. This case suggests that the immunoglobulin E pathway might be an unrecognized contributor to the autoinflammatory cascade in certain Behçet's disease patients. The global challenges of the modern era have also touched the lives of those with Behçet's disease, particularly the coronavirus disease 2019 pandemic. Emerging research has explored how the virus may trigger disease flares in patients who were previously in stable remission. A case report highlighted a 35-year-old woman who had been in remission for 2 years while on colchicine until she developed new-onset erythema nodosum, like lesions, and subsequently tested positive for the virus. Advanced imaging with positron emission tomography revealed active vasculitis in multiple lower limb arteries, indicating that the immune upheaval caused by the virus can reawaken the underlying vascular inflammation characteristic of Behçet's disease. This specific case required aggressive escalation of therapy to tocilizumab, an anti-interleukin-6 agent, to control the flare. As we look toward the future, the research agenda for Behçet's disease remains vast and critical. There is an urgent need for the discovery of valid and reliable biomarkers to aid in early diagnosis and to accurately monitor disease activity. Currently, the diagnosis still relies heavily on clinical classification criteria, such as those established by the International Study Group in 1990, which require recurrent oral ulceration plus at least 2 other characteristic features. However, because the symptoms are often intermittent and can appear over many years, the delay in diagnosis is frequently significant, sometimes exceeding 5 to 10 years, which can lead to poorer outcomes in cases with neurological or major vascular involvement. The impact of Behçet's disease on a patient's quality of life cannot be overstated, as chronic fatigue, persistent pain, and the psychological stress of unpredictable flares take a heavy and often hidden toll. While organ-specific flares require specialized medical intervention, a holistic and multidisciplinary approach that includes physical therapy, occupational therapy, and psychological support is essential for effective long-term management. By continuing to unravel the complex genetic, immunological, and environmental threads that weave the fabric of Behçet's disease, we can hope to develop more targeted therapies and eventually find a way to silence this silent road traveler for good. This variable vessel vasculitis serves as a reminder of the extraordinary complexity of the human immune system and the devastating consequences that arise when its regulatory mechanisms fail. From the painful apathy of the mouth to the life-threatening aneurysms of the pulmonary system, every manifestation of Behçet's disease tells a story of underlying vascular inflammation. The case reports of thalidomide and omalizumab provide us with tantalizing glimpses into the potential for personalized medicine, where treatments are tailored to the specific cytokine profile and comorbidities of the individual patient. Furthermore, the interaction between viral infections like coronavirus disease 2019 and Behçet's disease flares underscores the need for constant vigilance and adaptive management strategies in this patient population. As clinicians and researchers, our goal remains the timely and accurate diagnosis of this condition to prevent irreversible organ damage and to improve the somatic and psychosocial well-being of those affected. The journey from the ancient Silk Road to the modern molecular laboratory has been long, but every step forward brings us closer to a better quality of life for our patients. The resilience of those living with Behçet's disease is truly inspiring, and it is our collective responsibility to ensure that their struggles are met with the most advanced science and the most compassionate care available. Through continued international collaboration and the development of more precise diagnostic tools, we can move closer to an era where the diagnosis of Behçet's disease is no longer a source of delay and uncertainty, but a pathway to effective and life-saving intervention. Thank you for listening. The titles for the referenced papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.